Hi, good evening and welcome. Thank you for joining our OncLive webinar, Guiding Nurses on HCC Management During the Era of COVID-19. I'm your moderator, Danielle Jameson. I'm a Scientific Director for OncLive, and I'm very happy to be with all of you today. The mission of this webinar is to provide our listeners with a free-form discussion on how nurses have been impacted by the COVID-19 pandemic. We will cover a list of topics that our panel will go into in greater detail on sharing insights from the front lines. The topics that we're going to be covering today will be the impact of the COVID-19 pandemic and how it's affected daily nursing routines and clinical practice in HCC management, PPE guidelines and shortages, nursing involvement in telemedicine, and also interactions with patients, easing anxiety and their concerns. Joining us today, we have Amy Hilsman and Abigail Smith, and I'll ask each one of you to introduce yourself and give your title, affiliation, and a little bit about your practice background.
I'll begin.
Hi, my name is Amy. Oh, go ahead, Abigail.
My name is Abigail Smith. I am a nurse practitioner in outpatient GI oncology, specializing with HCC patients at the University of Pennsylvania. I've been there for 6 years now, and certainly right here in the heart of Philadelphia. So we've had our challenges when dealing with COVID, and certainly with this patient population. And I'm excited to be here and talk more about it tonight.
I'm Amy Hilsman. I'm a nurse practitioner at Georgetown Lombardi Comprehensive Cancer Center in Washington, D.C. I, like Abby, specialize in GI oncology. I've worked there for 4 years, and we too have had challenges that I'm excited to talk to you guys about.
Thank you both. So we do encourage the submission of questions during the webinar, which will be addressed in the Q&A portion at the end of the program. Thank you for joining us tonight, and thank you to our nurses here with us on our panel. To get us started out today, I just want to start out with the current COVID numbers. So currently to date, the number of global confirmed COVID-19 cases are over 4.7 million, and the U.S. officially has the most confirmed cases at over 1.5 million, with now over 90,000 deaths. Nationwide social distancing measures are still encouraged. However, many regions are beginning to open up their economies, the regions with lower rates of infection, and they're beginning to lift some of these measures. While we've all been affected by these measures, we must take some time to acknowledge and recognize those that are on the front lines, like our nurses here today, working tirelessly in all therapeutic areas to ensure patients are receiving the care that they require. Their contributions cannot be overlooked, and today we're here to discuss how they're adjusting during these times. With that, I'd like to turn it towards one of our first topics today, which is the impact of COVID-19 on your daily nursing routines and clinical practices. Abigail, what are your thoughts on that?
Sure. So I will say it dramatically changed our practice, certainly in the outpatient setting. When COVID first became problematic, we really limited our patient visits, and really as providers limited our time in the outpatient setting. So it was a matter of really coming together as a team and working closely with all members of the team along with the patients, and whether switching patients to telehealth visits or seeing if certain visits could be done a different way, with incorporating visiting nurses at home to ensure that patients are safe and well, and utilizing just so many other resources that we haven't previously done before. So it certainly changed our practice. And now as we're kind of going through these past 2 months and looking at Resurgence, we're kind of seeing how the next few months will pan out, and what we do with our patients and how we bring them back safely to clinic, and really how we continue to limit the patient visits, and ensuring that we're keeping social distance practices and all the necessary PPE precautions in place as well.
Great, thank you. Amy, how about you?
Yeah, similar to Abigail, we had a lot of changes too. Our practice is currently running at 60% telehealth. And so we had to also change our clinic structure. We tried to make sure that within the subspecialties that no provider, be it a physician or a nurse practitioner working in the same subspecialty, were in clinic at the same time, or if they were in clinic, it was an abbreviated time, so that if there was exposure or if, unfortunately there was positive providers, that not everyone within that subspecialty group was exposed or positive at the same time.
Okay, that's a great point. So just to get us started off, looking at patients with HCC, do you think that they're at a greater risk than other patients or other oncology patients? And does COVID-19 does the HCC put them at a higher risk for hospitalization? Amy, do you want to start us off with this one?
Sure. I think all cancer patients are probably at an increased risk because they have a comorbid condition, right? The cancer. But especially those that have myelosuppression and specifically neutropenia, those are the ones that you have to worry about probably a little bit more. With HCC, you not only have the liver cancer itself, but you also have the diseased liver. So your patients are having cirrhosis, their liver's functioning poorly. So that gives them also, should they get COVID, then they are at an increase of poor. And another thing to consider is with these COVID-19 patients, a lot of the time you will see liver abnormalities. And so with an HCC patient with the background of cirrhosis, then that's also something you have to be mindful of, and it's concerning.
Abigail, so when looking at your HCC patients, how do you stratify their risk?
Sure. So going along with that same thought of other comorbidities. So looking at, do they have lung toxicity issues? Do they have other lung comorbidities? Do they have cardiac comorbidities? So I would say the more comorbidities a patient has, along with the treatment that they are on, does stratify their risk category, and can certainly determine how we are treating them and whether we will continue to really limit their time in clinic and encourage them to stay home as long as possible.
So are you taking any extra care for the patients with HCC than you would take for a normal oncology patient for another form of cancer?
Sure. So I think we're utilizing similar resources. So for instance, for patients who are on an oral agent with HCC in an attempt to limit their clinic visits, we may incorporate home nursing care to draw labs at home, certainly to have that other set of eyes at home, just to assess for any toxicity that the team can be notified about. So I would say we're certainly on a heightened sense, trying to alleviate any big issues that may arise from them not being at clinic and not having that face-to-face encounter. And then certainly through our telemedicine. So we really try with our patient population always use a video telehealth rather than just a phone call, because that way we can really get a true sense on how that patient is doing. But that isn't always feasible for certain patients. And so that there's a challenge that lies there within.
Amy, what precautions do you advise that your patients take at home and during their daily activities, since they are at higher risk, to protect themselves from COVID-19?
Sure. We talk to them about minimizing their public exposure, washing their hands frequently, avoidance of touching the face, wearing a mask out when in public, importance of social distancing and avoiding sick contacts, and also just making sure that their surroundings are clean and disinfected. Another thing that we talk about is if they come into the hospital, we encourage them to, go home, either sponge off or shower off and change clothes out of the clothes that they came into clinic with.
Oh, great point. Abigail, did you have anything to add to that? Are there any additional precautions that you're having your patients take?
Nothing too much else, just really aside from if they do have symptoms and such as respiratory symptoms, GI symptoms, or really any new symptoms that they're concerned about, but also for them to continue to monitor their temperatures and really to make sure that they contact us before they go to the emergency room or something like that. So really trying to encourage patients not to have a knee-jerk reaction to go to the emergency room, but really to touch base with the team first. And that way we can kind of go over what would be the best option for the patient at that time.
Amy, with all of this stress with having cancer and while we're under all of the stress with the pandemic, how do you find that your patients are emotionally handling all these additional challenges of COVID-19 during their cancer treatment? Did we lose Amy?
I can jump in on that one.
Yeah, would you mind? Thank you.
Sure. So what I will say, and what I think, because now we're at the really 2 going on 3 month mark, and what I'm seeing more and more is just patients are really lonely. So now it's not only just looking at the physical component of all this, but really the mental anguish some patients are feeling, and really the isolation that they're enduring, and just trying to encourage patients to really motivate themselves to at least exercise, get up out of bed, and really to just try and bring their spirits up. So I think that's been the biggest challenge right now, as we're seeing that patients have been quarantining for 2 months, and they're really just a lot of them very lonely, and because of the lack of activity, patients are just saying that they feel more weak, and certainly feeling more symptomatic. That isn't necessarily from their cancer, but just trying to again look at the whole patient at this time, and encouraging patients to really take care of their mental health as well.
Is your center offering any kind of programs like for emotional support for cancer patients?
Yeah, so I will say our social work team is wonderful. So I'm oftentimes utilizing my social worker at clinic, but then also for our patients that are receiving nursing care at home, utilizing those resources and those social workers through whatever agency that they may be using. So that, and then also incorporating their family members as well. So again, going with a lot of our visits being telehealth as certainly as much as possible, just ensuring that family members are on the phone call, and if they're not able to, that we're engaging with those family members as well, and just making sure that everyone's kind of on the same team here, looking out for that patient and their overall well-being.
Okay, great. Thank you. So just switching gears now, talking more about treatment decisions and how those have changed in the realm of COVID-19. Generally speaking, how do you think the treatment for HCC has changed?
I can jump on that too. I don't know if Amy's back on.
I think she is.
Are you here? Sorry, I had technical difficulties. Sorry, I just got back. I'll speak to that.
Okay, great.
So for treatment and the changes, a few things that we have seen is, possibly deferment of treatment, and that's across the board. Chemotherapy, the TARE, the TACE treatment, surgery, risk benefit, and is it a good idea? A few other things that were that we talked about is we may consider liver-directed treatment or radiation over surgery. And then again, IV or oral treatment. And sometimes we choose oral because you can take that at home. You don't have to come into the clinic as often. Patient preference also plays a role in that. You want to make sure you're having a personalized conversation about, your thoughts and what they're thinking, and match that as closely as possible. So that, they feel comfortable with what's happening to them and for them as well.
So I'll hand this one over to Abigail. For those patients who are symptomatic for COVID-19 and are receiving TACE or TARE, how are you managing those patients?
Yeah, well, first off, now we've restarted all those procedures just really in the past couple weeks. All of our patients are being screened prior to the procedure for COVID. So everyone's being screened. And certainly if a patient is positive for COVID, then that procedure or treatment is delayed until they have 2 negative COVID tests. So, so certainly there's that consideration. And it has, fortunately, knock on wood, we haven't really come across that yet, where we've had a patient recently have tear, TACE, or that's undergo that and test positive. So, but certainly if that were to happen, we would, and if they're mildly symptomatic, we would certainly have them quarantine at home and try and do telehealth video messaging. Now, if their symptoms become more severe, if we're concerned that they may require oxygen, or if there's worsening of their breathing, then certainly at that point we would need to have them come to our emergency room and notify the ED at that time and bring them in, and just making sure that certainly all teams are notified and aware. But really we're trying to minimize that by screening everyone prior to procedures at this point.
Amy, are the screening procedures very similar at your center?
Yes, we require for elective procedures 3 days to be tested for COVID prior to the procedure. So that's something to consider for your patients that maybe need a paracentesis and they're wanting a quick turnaround. They have to have, a test for COVID first, so that delays their paracentesis. So you may have to talk to them about, how to be more comfortable until they can have that. But yeah, very similar to Abigail.
Amy, going back to your original comment of oral versus IV therapy, have you had a good deal of patients switch from IV to oral therapies?
We haven't. Most patients have just kind of stayed on the same treatment. What we may have done is delay their cycle or offer a dose reduction, especially in those patients that, are a little bit more brittle in their care or having more side effects to hopefully keep them out of ER and urgent care and that kind of thing and having increased toxicity. But for the most part, we haven't done drastic change. We also, I don't know if Abigail in her clinic has done this, but we have not implemented or structured any guidelines for the oral or IV. It's basically case by case and very individualized.
Okay. Abigail, is it similar with your clinic, or do you have guidelines?
I would echo what Amy said. We don't have specific guidelines. With the IV treatment, initially we were delaying. If a patient was stable, we were delaying the IV treatment to the and maybe pushing out a month or two, and even pushing out scans if we didn't think that there was clinical concerns at the time. And for a patient, similarly, even on oral agents, to maybe holding for a cycle if we didn't want the patient exposed to going to a lab. But at this point, we've pretty much resumed everyone back on their treatment, and our radiology department is certainly open full force. So we're kind of back, and everyone's back on their standard dosing. But I will say, with that being said, it doesn't mean that we're bringing them back to clinic at this point, and really still utilizing outside labs or home labs and telehealth.
Okay. Amy, what has been your interaction with pharmacists and the pharmacy during this? Are they taking any measures to give, for the patients on oral, are they taking any measures to give larger day supply so they don't have to come into the pharmacy as often?
Not to my knowledge. Most of the oral agents come from specialty pharmacy, so they're shipped directly to the patient's home, so that's nice. You don't have to worry about them getting out. And then a lot of the local pharmacies have implemented deliveries, so that's an added benefit for the patients, or drive up, drive through. And so the patients really aren't having to get too much exposure and trying to get their medications.
Okay, that's great. So moving on to side effect management, what are your how have you changed side effect management during COVID-19? I'll give this one over to Abigail.
Sure. So prior to COVID-19, we as a department did not do any telehealth, telemedicine. So this was all brand new to us. So now with side effect management and really switching mostly to telehealth for all of our oral patients, we now really try and encourage the video. So making sure that if we are doing telehealth, that we are having a video phone call so we can truly assess maybe the hand-foot syndrome or some of the side effects that may be occurring. And then and then also we have through our portal where a patient can upload photos, and certainly we can assess through that standpoint as well. And then also in addition, for those patients who are coming into clinic, our nurses are actually calling the patients the day before to assess them over the phone as well, to see if they are presenting with any concerning symptoms of COVID, or if they feel like that the team needs to reach out prior to them to come in if there's issues that we need to address beforehand. So that's all been brand new for us, and it's been working out quite well, and we're really able to minimize really severe complications that could arise from us not being aware of potential side effects that have been left unmanaged.
Do you think that you'll continue a lot of these measures even after COVID-19? Have you seen good outcomes with them?
We have seen good outcomes. So yes, as of right now, I don't indefinitely. I think that telehealth is now going to be here and it will stay. And I think that's certainly for the benefit of the patient. So I think that will certainly stay. And I think it's been really a wonderful resource to have all of our patients who are coming in to be screened the day before. I don't know, at this point that's ongoing and no end date for that, but hopefully that will continue to be the case, because we've really been able to make sure that patients are coming in that potentially do have exposure risks or that really need to stay home.
Thank you. Amy, what additional measures is your clinic taking for side effect management?
So we're doing very similarly to Abigail. One thing too that we really try to push is education of the side effects, and to let us know, sooner rather than later. And I always tell the patients, we don't want you going to urgent care or ER if we can help it. So it's really important for you to report things, even if it's very, very mild, so we stay ahead of it. I think they've been receptive because there's the fear of having to go into the ER and they don't want unnecessary exposure. So with the telemedicine visits, they're able to get to us easily without having to get in the car. They can get an appointment a little quicker. And so that definitely has been helpful.
Great point, Amy. So looking at specific agents that are used for HCC, what are your perspectives on managing side effects with TKIs versus with immuno-oncology agents? Amy, if you wouldn't mind with that one.
Sure. Well, the side effects are a little bit different, right? So with immunotherapies, you're worried about autoimmune side effects. And so again, it's just the patient reporting symptoms. It's, as we're treating, what we're trying to do is limit their myelosuppression, but also grade 3 and 4 toxicity, right? Because that's what would push them over into the urgent care or ER. And so as they're having symptoms, they report, and then you can manage those. And with immunotherapies, as you know, most of the time you can hold the dose, treat with steroid, and get the symptom under control. And then with the TKIs, you're just making sure, the skin is probably the most important thing. Energy level is something to be concerned with, but the skin, you just want to make sure that they're not having, openings or blisterings or any kind of infection-like problems related to those medications.
Abigail, did you have anything to add to that?
Yeah, and you know, that just with to echo all of that, but then certainly it adds a whole level of complication when we're not bringing our patients in, and we're not seeing our patients as routinely as maybe we once were. So with those patients that are having those skin issues, the skin toxicity is, you know, certainly we have those patients who underplay their side effects, and if they do live at home alone, if they don't have someone there with them, then I certainly helping to see where other resources may be needed for that patient. For instance, getting nursing care at home to really help evaluate the patient. And we don't want to make sure that those patients who are on those oral agents, that they kind of fall through the cracks and we're not seeing them, or that someone is certainly laying eyes on them, just to really get a good handle on the side effects that they are encountering.
Did you find yourself like routinely checking up on patients somehow, just to make sure that you're monitoring them?
Yes, I would say I'm a little more even heightened now with it, and it's certainly for those patients who we do have that patient population that may not even have a smartphone, may not have a computer. That older patient population who really is homebound and with limited social interaction. So, you know, certainly I do find where I'm, you know, calling those patients maybe a little bit more, or just really trying to follow up with them and making sure that we don't lose track of them, and that they are still doing well at home.
Amy, did you have anything to add on this additional need for monitoring with these patients?
One of the things that's been a little bit interesting for me is most of the people, you know, are working in a limited capacity outside of the home. So that adds an extra layer, because the patient, although they may not be able to use the computer well or their iPhone well to get on telehealth, a lot of times, or more frequently, someone in their family is available to help them kind of get their computer connected, to get their iPhone up and running. And that's been an extra layer of support for the patient, because if it's the family member that was too busy to come to an appointment or always traveling, and now they're not, it's nice because we get to make a rapport and a connection with the family member that maybe we wouldn't have done if we were having in-clinic appointments. But also the patient is getting some, you know, involvement from the family member in another way too.
Oh, that's a really good point. So Amy, with some new and emerging therapies, particularly those with immunotherapy that we mentioned earlier, atezolizumab and bevacizumab, what are some of the concerns that you might have with those agents?
Well, I think, you know, because they're combined, you have to worry about a little bit more intense toxicity. And we do have several patients that are on that. And then there's also Nivo, and ipilimumab was also recently approved. And so we've started treating some of our patients with that. Again, it's just education of patients, letting them know what to report, and good follow-up from us to help them with the recognition of the toxicity.
Abigail, did you have anything to add there? How are you managing your patients that might have concerns with initiating a new therapy?
Sure. I would certainly echo all of that, and that really education. It comes down to educating the patient, but then also their family members as well. So really just ensuring that the team at home and their family, their support care at home is aware of what to be monitoring for, and what we should be notified about. So just ensuring that they feel comfortable reaching out, and that they recognize that we don't want them going to the emergency room. We want to be the first team aware of what issues that they are facing at home.
Thank you. Another important topic that I know we've touched on several times is telemedicine. It's becoming really important in the management of many different diseases. So let's talk about a little bit about nursing involvement in telemedicine. So if you wouldn't mind, I know we've touched on it about how telemedicine is being used in your role and at your institution, but did you have anything to add about benefits and challenges that you've seen, Amy?
I think it's a little bit, it's a more personal visit. It's less formal. The patient isn't having to come in and sit on an exam table in a sterile environment. They're in the comfort of their own home. So there's a different openness to the visits, I would say. And again, the family participation has been important, but also it's easier for the patients that drive 2 hours or longer to come in for their appointment. You know, there's less hesitation, I think, to report because they know that they can get us in through the phone or the computer versus us saying, "We'll come in, we need to see about you." And so I think they're a little bit more forthcoming with side effects. And so I do appreciate that. And I think the patients like the visits. I haven't had patients become grouchy or complain too much. So that's an important thing. You know, I think some of maybe the two cons. One is the limited exam, right? Because we're dealing with liver cancer. You can't obviously palpate the abdomen or tell about ascites or that kind of thing. You can't tell what's going on with their lower extremities very well. You can ask them to move the camera, but it's still a bit limited. And if you're worried about jaundice, that's a little limited too. And then I think maybe the most important thing, though, is that patient contact. While there is a personal touch with telehealth, when you're in the exam room with someone and you're looking them in the face and you can pat them on the shoulder or give them a hug or a handshake, that does something that you can't capture through telemedicine.
Yeah, that's a good point. Abigail, did you have anything to add about benefits and challenges?
Yeah, and going along with that, and certainly patients are more likely than not to no-show. They're going to be there for their visit, and they do often having that comfort. It is a more comfortable visit. It certainly allows patients to be at home, and then certainly to incorporate their family into the visit as well. But the challenge is obviously, yes, not able to really assess their abdomen, really palpating the liver, assessing for ascites. And I think just always not being able to see the patient move and how they're walking, how they're ambulating, and really sometimes too lighting, assessing the jaundice or hand-foot syndrome. Some skin toxicity issues can certainly be challenging. And then again, patients who don't have that video access, that can be problematic as well. But it certainly is a really good alternative at this time and really helpful.
Do you find that having the families at home can be helpful maybe to uncover some symptoms you might not have heard about if the patient was coming into the office by themselves?
Certainly. Yes. And I think what's also really helpful too is that family members can have their questions answered, and it eliminates the extra phone calls that can happen. Right now in our clinic, we have a no visitor policy. So inevitably, I mean, certainly for some of our patients, we'll conference call a spouse or a daughter in or a son. But oftentimes the people really still want their family a part of the visit, or we can't conference call everyone in. So it allows for the family to be involved and ask all their questions, and everyone's on the same page. So there's no miscommunication. So that's all, I think, a little bit of a perk for it.
Yeah. So just with some of these perks that you've seen, Amy, how do you see this changing telemedicine at your clinic in the future?
I think telemedicine's here to stay. I think if anything, it will change the flow of the provider's schedule and their clinic time, right? And how do you accommodate, how do you keep these visits? Because it's a good service. It's a good service for the patients, and there's an ease to that service.
Abigail, did you have anything to add?
Yeah, telehealth, I think, is here to stay, and certainly with the reimbursement improving as well. So that's always a little bit icing on the cake for that. And then also from a clinic standpoint, even though we're going forward, we still have limited days that we're in clinic. We're now allocated and encouraged days to work remotely, to have telehealth. So certainly for the provider, and I know for our nursing staff, this is certainly a little bit of a benefit as well. All of our triage nurses are working from home full time at this point. And really that's probably going to be the case for many months to come, and there's no end date to that. So
do you see that the provider is able to see more patients in a day? Are these visits ending up being a lot quicker than a typical visit?
From our experience, they've been quicker. For I think patients, because they're home, it's less stressful. They're not as stressed. It's a quicker visit. So in a lot of ways, we are able to see more patients via telehealth, and patients that seem generally happier. And there's not so much of a wait time. Obviously, that's always a source of stress when clinic is running behind. So yeah, I think patients are happier, and probably providers too in a lot of ways.
Amy, what kind of feedback have you been getting from patients around telemedicine?
Yeah, they love it. I think the biggest setback is if you have a technical problem or the patient or family member doesn't know how to connect, and then you're having to, do a few extra steps to get them connected and phone calls or this and that. And then maybe that puts your day behind. And that's been the biggest issue, just getting people used to how to connect to the link without impacting the rest of the day.
Oh, right. All right. So now I just wanted to move on kind of to some of the ONS guidelines that have been given. So around gowns, the disposable gowns, and masks. So using a mask and eye protection required only if splashing is likely and for spill cleanup. Have you incorporated these guidances from ONS into your clinic settings, and how have those been incorporated? I'll start with Abigail.
Yeah, so we pretty much incorporated all of those recommendations in one form or another. So in clinic, most of us are wearing scrubs and wearing sneakers that we, know to really not bring into our home or keep away from other clean areas in our home. And then we're all our temperatures are being monitored before we come in, and everyone certainly has to wear a mask, but then we're also wearing eye goggles or a face shield as well. And with regards to if a patient we were concerned potentially could be have active COVID, then we would certainly gown, glove, and put on an N95 respirator mask at that time.
Amy, how about you? Anything different at your clinic, or any additional precautions?
Yeah, so we're doing the similar things. The only thing that's different, the staff are not wearing goggles or a face shield. We have screening on the outside of our clinic. So if a patient comes through and is febrile or having any symptoms, they're sent to another floor for COVID testing. They're escorted up, and then they're tested there. So it limits if we have, exposure for the provider. And then same thing, before they go into infusion, they're screened a second time. And we have had some patients come through clinic and be afebrile, and by the time they get to infusion, they're febrile and they have to go to the COVID clinic. So I think that's the biggest difference between Abigail's clinic and ours.
I know that PPE shortages have been something that's been in the news a lot. Have either of you had any issues with that at your clinics, either in the past or currently?
Yeah, well, even now we're certainly reusing our masks. Our masks with the face shields, we're reusing them until they're soiled is basically what we've been told at that time. Now, we can get certainly another mask, but we're not disposing of our surgical masks one patient after another, as typically prior to all this, certainly if you saw a patient, you had a mask on, you would throw it out after you saw that patient. But right now we're using it until it's soiled, or if we feel like we need a new one. So really just trying to limit the new PPE that we're getting.
Amy, how about you?
We're using ours for the day. So every day we get a new one.
Okay. So I guess a question that is on everybody's minds is, now that restrictions are being lifted, what is going to be changing about your cancer center or clinic going forward?
Yeah, so the first week of June is, and we've actually had many meetings over these past couple of weeks, is our Resurgence plan. So now, actually, after telling patients to stay at home, how do we alleviate the anxiety and stress and tell patients that it's actually safe to come back to clinic, and it's safe to come in and get their scans, safe to come in and get the paracentesis or their tear, taste. So we're certainly resuming all procedures at this point, and just trying to encourage patients to come in and let them know that we're still being safe, certainly with the Resurgence plan that's taking place.
So Amy, how about for your center?
The same thing. We don't have anything formalized just yet about Resurgence. We're, kind of looking at that. But also, as we're starting to move forward with more elective procedures and more surgeries and opening up the OR and increasing the volume back to the hospital, then you kind of have to worry about your patients maybe a little bit more and say, okay, there's going to be more people coming through the hallways, and is that going to impact the oncology patients? That's something to think about and consider.
Do you find that your patients seem hesitant to come back now that the restrictions are being lessened?
There's a few that are a little bit hesitant, and if they're stable, they may discuss holding things off a little bit more, and maybe needing the scan or the visit a month from now. But for the most part, I think at this point they've had such good education, and they know the and if they don't, we educate them before they come in about the routine and just to be safe and wash your hands and use hand sanitizer and that kind of thing. I think there's a willingness there.
So for either of you, what resources do you offer around COVID-19 for patients or caregivers, like educational resources where they might be able to learn a little bit about different precautions that they could take?
Certainly, we defer to the CDC guidelines and going to the website. And then there's also been within our system, we've made a bunch of smart phrases, and our department has made basically smart phrases we can hand out to patients and their family members that just is really just general information about COVID, about the precautions and signs and symptoms to certainly let us know about, and certainly things that they need to monitor for at home.
Perfect. Amy, how about you?
We've done all of those things. I think one of the things that we have implemented that has been nice is some Facebook Live sessions, which talk about things from not only COVID, but also nutrition and how to do a grocery shop. What are you looking for when you go in during this time? How to, minimize your time in the grocery store, and, spiritual needs or topics, mindfulness, yoga, stretching. We've had these on Facebook Live, and those have been, pretty popular. Patients look to those. And also, as Abigail was saying, we do have the flyer and the handouts about COVID and symptoms and what to report and such.
So how do you talk to your patients about kind of thinking about going to the grocery store and things like that? How do you talk to them about sort of the weighing the risks and benefits of their normal daily activities? Amy, if you wouldn't mind starting with that one.
Yeah, so we of course encourage delivery, or pick up, so you just drive up and you don't go into the store. But for those patients that want to go into the store, we encourage, wearing the mask. If you want to wear gloves, if you don't wear gloves, wash your hands. Make sure you're washing your food as you bring it into the home, making sure that you're not just kind of chunking it in the fridge when you get it home. So we've talked to them about that. A lot of them are doing, for ones that don't like to cook or they live alone and they, only need small portions, they may be doing meal delivery, which is, that's okay too. So yeah, I think that in this area, fortunately, we have a lot of options. And really, you could get away with not going into the store if you didn't want to.
Abigail, did you have anything to add there?
Similarly, being here in Philadelphia, there's fortunately are a lot of options and delivery. And then oftentimes patients are utilizing their family members. So many patients are saying, you know, I haven't left, literally have not left my home because my daughter's doing all my grocery shopping. And so encouraging patients to continue to utilize family members to help them with that. So that's probably been a big resource that a lot of patients use as well.
Those are all really great points. Thank you so much. So now we're going to go ahead and open up to the question and answer portion of the webinar. If you go up to the Ask Question and Answer box on the right corner of your screen, you can type a question directly into that space and then hit submit, and then I can see it on my screen. So I'll just start out with the first question that we received. What steps do you take to protect your family from COVID when you come home, when you return home from a shift? I'll start with you, Abigail.
Sure. So I wear scrubs to work, so or at work, I should say, and then just immediately coming home and throwing all of my clothes in the laundry. And I have a separate pair of shoes of sneakers that I only wear to work, and they stay by the door contained. And then I shower immediately. So you know, and certainly from hair standpoint, I pull back my hair, and I'm utilizing my, you know, mask and eye goggles too as well. But really just making sure that when I get home, immediately I'm getting out of those scrubs and showering.
Amy, did you have anything to add?
No, I do the exact same thing.
Do you or either of you find yourselves distancing yourself more just since you are a healthcare provider from other friends and family members? Maybe more than the general population would? Or do you take any extra precautions?
I went for a hike with one of my friends the other day, and she is in research, so she doesn't have, you know, one-on-one patient exposure and such. And I did keep my distance from her. I don't have symptoms. I felt great, but just in the event, right, she has kids, that I am an asymptomatic carrier. Yeah, I did keep my distance. Same thing with my parents.
So Amy, along the same lines, what precautions do you take around your COVID-19 patients?
So our patients that were COVID positive have to be screened negative before they come back to clinic. I think the biggest issue becomes if they're positive. For instance, we had a patient that came from a long-term care facility, and she came to us, went through clinic, met with, you know, the medical assistant, had labs done, the whole shebang, saw the provider, and then after the fact, the long-term care facility said, oh, by the way, we just found out she's COVID positive.
Oh,
so,
no.
You know, that's a problem because now we've exposed a lot of people unnecessarily. So that's, those are the kind of situations where it's like, okay, great. Now you have to trace everyone that was there that day and all of the staff that were around those, you know, and who was in close contact, and did she remove her mask, and was she coughing all over the office and that kind of thing. That's the more bothersome or you know, more concerning thing.
So Abigail, to go along with that, how do you contact trace? So if you find out that a patient did come in with COVID after the fact, what is the procedure at your clinic for contact tracing?
Yeah, well, so we're seeing this now more because of the fact that we're screening more patients, and we're screening more patients. So for instance, a couple weeks ago, I had a patient who I saw completely asymptomatic, felt great. Well, the following week he was getting a procedure done and he tested positive, just routine screening, and continued to be asymptomatic. So I got a call from my attending, who got a call from ID. So certainly there's a trail, and then we have to notify the manager, and then again waiting for that patient before that patient comes back to clinic has to have 2 negative COVID tests. So it is tricky because now we are certainly now seeing patients who have already actually been to clinic, and then later on we're finding out that they're positive for COVID, and it's just a matter of notifying other providers who may have been in contact with that patient, and if they were potentially didn't have proper PPE on, that they may need to quarantine for a week or so. So it's kind of just making sure that everyone who did have contact with that patient is certainly aware of that patient's status.
So we just had another question that came in. For the application of, for the administration of quicker medications like subcutaneous administration, have your protocols changed at your clinic at all? Amy, I'll give that one to you.
They have not. I'm trying to think of a medication that would be sub-Q administration. Abigail, are you thinking of anything?
Yeah, so for like our lanreotide patients, so we actually tried to, we're having a big problem with that. So initially it was thought, well, let's just move all those patients who are getting something like lanreotide to home care. They can just get it through the visiting nurse. But the problem that we're finding is the copay cost. So patients cannot afford that $800, $600 copay cost. It's cheaper for them to receive the injection in clinic. So many are not receiving the injection through home care. We delayed it maybe a month, but now they certainly need to come in for that injection, so it's bringing them back to clinic. So we've had issues where that we thought it would be a nice, easy fix, but that's not been the case so far. So we're hoping, we'll see, but that would be helpful in the future, or certainly now, for insurance to really cover the same for home injections versus in clinic. But as we know, insurance costs can differ.
Thanks for addressing that, Abigail. Amy, this next one is for you. How has COVID changed your view on the U.S. healthcare system?
Oh, wow. We don't have enough time.
That's a big one.
Big one. I think some good things, the fact that the telemedicine thing transitioned very quickly. Insurance, carriers are willing to pay for it, and Medicare and Medicaid are on board, and that was turned around, really quickly. I think that's good. I think one thing that's important to think about as we're bringing these patients in frequently, maybe we're bringing in some of these patients too frequently, right? Mm-hmm. If we've delayed the scans, if we've delayed treatment, if they've been a little stable, it makes me question, are we overseeing patients sometimes? Maybe we're on the cautious end of things, and maybe we should be mindful of healthcare dollars and seeing patients a little bit too frequently. Same thing with scans. You always have NCCN guidelines gives you a window, 3 to 6 months or 6 months to a year. And in this case, we're going to that far other edge of the window. So does it make sense as well, because these things that we do to these patients and treat the patients with, their high dollar expenses.
Yeah, those are really good points. Abigail, did you have anything to add?
No, they were great points, and certainly it's a deep question. But I will say what is impressive is just the healthcare field as a whole, and certainly the nurses, physicians, and really the whole team, and just how everyone is able in the midst of a pandemic to really come together and working as a team for the betterment of the patients, and really just keeping the patient's best interest in mind, and certainly in an attempt to protect each other. And I know from our team standpoint, just how great it is being able to work with other providers who really we take care and caution with each other to ensure that everyone's doing well physically, emotionally, mentally, and ensuring that we're all staying safe and limiting our time in clinic as much as possible. So I think there's a lot of positives that have come out of this certain pandemic, and I think it really just shows the courageousness of the healthcare team and how everyone does really work together so well.
Absolutely. So I'll let you start off on this next question that just came in. Have you changed anything regarding diagnosis of new cases? Like if a patient was scheduled to come in because they were worried about potential diagnosis, have you changed anything to that process? Are you delaying those appointments?
Yeah. So unfortunately, what we found, because things, certainly from a GI standpoint, and seeing things like colonoscopies being held up where patients weren't able to get their colonoscopies. So initial diagnoses weren't being made, and so there was certainly a delay. So now I think we're at this point where we have really opened back up on our procedure centers as well. So now the influx of new patients has actually really started to pick up this week and in the approaching upcoming week. So it was, we didn't really see a lot of new patients for a bit, or I would say a smaller volume of new patients, where now patients are coming to the forefront and really just trying to now expedite their care and making sure we're doing everything as quickly as possible.
Great, thank you. So looking at just as the appointments pick up and having caring for so many patients, I know that burnout can often occur. How do you find as a nurse that you overall just keep yourself safe from burnout after working long shifts?
Meditation.
Amy, I'll let you start with that one.
Yeah, I think it's important. Meditation and self-care is really important. And to use your colleagues, the NPs and I that work together, I share an office with a few. We kind of debrief, especially now given all of the COVID stuff. So we'll just say, today's really been difficult. Let's talk about this. So we'll have a chat. We've done a few happy hours on Zoom. And that's fun, just to talk about other things, not the virus or not patients, just personal fun stuff.
Yeah. Abigail, did you have anything to add?
Yeah, I would also just say exercise. Just at this time has actually been a blessing in some ways and has given more time for for self-care and just really trying to make sure that every day I'm exercising in some form or capacity. And same, Zoom happy hours are great, and really just making sure we all try and reach out to each other, weekly and just touching bases. Everyone doing okay with group texts and emails, and just really making sure that everyone is feeling well supported and that we're, certainly all there for each other to help out.
That's great. So another question that came in. So we've talked a lot about things that have worked at the institutions that you're at, things that have been implemented that have been really helpful, like telemedicine. Are there any programs that you initiated for COVID and didn't work out quite as well, and you kind of had to scrap it? Abigail, I'll let you start with that one.
I can't think of anything that's actually, I would say with everything that we started, it's just been expanded upon. So just with more screening, more regulations with regards to PPE, and now kind of going forward with the Resurgence. So still we are capping the amount of patients that can come to clinic. We're going to maintain like a 60% capacity, and certainly for the benefit of the patient and limiting their time in the clinic wait, and hoping that no patients really actually have to wait, and that they don't have to check in or check out, eliminating really close exposure to other patients within the waiting room areas. So if anything, I feel like the processes have continued to improve, and hopefully that continues.
That's great. Amy, so within your clinic, so as we start seeing patients back, do you have protocols in place in case we do start seeing a big spike in cases again for COVID?
We
have
do
you
not
kind of
have
planned
anything
for that?
No, we haven't planned for that. I'm sure, though, as the elective procedures and the surgeries and all of that, start coming back, and the new patient volume, we did some new patient communications over telemedicine, and would also have their cases presented in cancer conference or tumor board, so that they still felt like they were, being overseen and collaborated with throughout all of the departments. But we haven't really formalized what that looks like if there is a resurgence of the virus, or how that will impact our clinic.
All right. Well, that appears to be all of the questions that we have. Again, a huge thank you to our nurses, Amy Hilsman and Abigail Smith. Thank you so much for taking the time to sit down with me with OncLive virtually and convey these pivotal discussions to our listeners. Thank you also to our listeners, and I truly hope you were able to gain valuable insight about the care of your patients and how management is changing during this pandemic. So if you participated in the discussion tonight, you will receive a link to the program for listening back at a later time. And you can see our website, oncnursingnews.com, for additional updates from our leading cancer experts. Thank you so much.
Thank you.
And that concludes our webinar. Thank you. Have a great evening.